run through the last presentation. I mean, it does not come here.
It's come here.
So, we just heard, what all can happen. The wrong eye surgeries, wrong procedures, wrong IOL power, or you can even miss a diagnosis which can result in loss of vision or even sometimes loss of life also. So, there are two things important. One is you have to have a process. The second, you also have to have the culture of the safety. So, to err is human. That's something we have to understand. So that is where the process becomes important. But again, that alone may not be sufficient. The culture we have to bring in the team is also very, very important. I'll just run through some of the important things. The first and foremost thing, if you want to avoid such errors happening in your organization, probably you have to improve the safety. Create the awareness about the safety is very important. Bringing together everybody to understand how safe is your hospital is very important. Open sharing. And today, we are not, no ophthalmologist alone. Each ophthalmologist will have at least 8 to 10 people, either directly or indirectly connected to him. So, to have a clear understanding between the team is very, very important. So, that is where what goes wrong becomes important. What are the reasons for things going wrong? That's why, when you heard all these incidents, there is a lot of details. We really analyze what goes wrong and how do we make sure that doesn't happen again. And again, second is the important thing is how do you bring the culture of reporting. So we started with the paper form for people to report, but we didn't get any report almost for 4 or 5 months. But now if you can have something electronically, there are Google forms are there, WhatsApp is there. There are many things if you are able to have some way to report it so that everybody is aware. And again, not only reporting, but how there is a system for communication. Here, in our system, once it is entered, the information goes to the chief medical officer and 4 or 5 people who are in charge of the safety in the organization. And again, giving clarity to the staff. That is where, the safety goals, it becomes very important. How do you define? That's what Dr. Haripriya said. The 10 goals, and each goal you have to understand how it can be prevented in your own practice. You have to write up your own protocol for that. And again, the important thing you have to understand is all these errors are related to the work process. You have put the protocol you are following is the root cause for all the other thing. In Aravind, because a lot of delegation happens, each person does one work, which means, there is a lot of handover. At least about each patient is touched by 12 to 15 people in our organization, which means, we have to make sure that identification is a fundamental thing. If you don't identify the patient, we are going to end up. You have to find out what is that important thing in your own organization. Again, the common thing is transcription error. What is the system you are going to have? You just heard from Dr. Shivakumar what we do in our organization. And Dr. Haripriya talked about in detail about timeout and OT. We do it not just in the operating table, but at 5 other different locations. And just to document that, we also have safety checklists, either paper or also on EMR. And again, what is important is the monitoring, whatever that has been reported, somebody have to look at it, and then we have to analyze it. This is a kind of a 1 year what happened in the counseling department. So these are all, these do not result in any incident, but making sure that even that counseling department is able to report. If you see, the counseling department reported 302 errors. These 302 errors are about the doctors usually, or about the biometry team. And about the counseling department, the people downstream, like the medical record department or people in the ward, they report about them. And again, now when you hear all this, doesn't mean that you have done some changes, it's not going to stop. You have to constantly redesign that. So the wrong eye block is a common thing. So we went with 2 markings. It didn't help. And that is when we had a paramedical staff, and that considerably brought down the incident. Now there are 2 people have to be there when a block is given. And again, using technology, earlier we used to have a paper record. We have to make sure that the medical record number and the EMR number, everything matches. But since we had these errors, we made sure that only if you enter that last 3 digits, that card is only with the patient, not anywhere else you cannot get this number, and only then the EMR will open. And similarly, a doctor's, like Dr. Haripriya said, a right eye mature cataract, it was wrongly advised left eye. So the EMR will also ask whether it is really a right eye. No, then there is an opportunity for the doctor to re-verify. And again, Dr. Shivakumar talked about how do we check the power of the IOL in the store before it is dispensed. I mean, this is all what we do in Arvind, but you have to understand what is it you are going to do in your practice. And in a constant reinforcement is very important. It is not one person's work, it's a teamwork. I think you have to delegate and also empower the staff so that we can minimize these errors. And safety is a way of thinking and acting wherever you are, whether it is work, home, or leisure. Safety is everyone's responsibility, and we should feel comfortable to report any safety issue. That's a level of transparency, the ease of work you should bring in your organization, and this should become a part of the organizational culture. And you need to invest in the people's potential. Thank you. So if there are any questions, anything you want to ask our team, we'll be happy to answer. Maybe we have 5 minutes. Anything you want to add, Haripriya, Kumar, maybe another 5 minutes we have, so you can give your inputs.
I think we all have to start with something small, like starting with checklist, and then if any just monitoring with small stuff. The incident reporting we find to be very useful. So any small deviation, also the staff encourage them to report. And again, the idea is not to penalize, so that you'll have to just understand what the problem is, and that gives them a reassurance that someone is listening to them, and we're actually helping them overcome the problem. So that has also helped us in a big way.
Can I ask a question, sir?
Yeah, please. Yes,
yeah. A wonderful talk. Sir, now you have been doing so much of thousands and lakhs of surgeries. Definitely, the safety has to be the first priority, and we are already doing it, and Haripriya Madam has already published a wonderful paper. My question is, when you are doing so many eye camps, now we are tagging it with free, too many free things we are buying it. Now there are few concepts which are coming, that people who wants to go in for a premium lenses or something, then you need to have the counselors at each of these camps when you are going around. So what is your take on that? Should we do that, or should we not do that? Or should we remove that word free eye camps and just say that it is eye camp so that the conversion would be possible? Or how do we teach our patients how to become a better patients?
We'll ask Haripriya to answer.
So we normally in the eye camps, we only bring in, so it is along with the NPCB, so our camps are sponsored by the government. So the patients we bring in through the camps, they don't pay, so they are completely free. Those patients who are willing to have surgery with a foldable lens, which we don't do through the camps.
How do they know that there is an option called as the foldable lenses?
So I think in today's world, everyone knows, but if the patient, like example, most of them would have come and said, I want, we don't say it from the counselor's side, we don't promote it at all. Okay. But if the patient says, I want to come into I think they know that they have a better option in terms of a lens, then we'll refer them, and we have a separate count of how many we refer, and we give them a card and say you come and meet this staff at this number, and that card they bring there. So we also track how many patients have come through the camp to the base hospital, or who are referred from the paying to the free side. All of this is done. Again, in the free, when they come with a walk-in free at least, we ask every patient if they have any insurance. When they say yes, then we refer them to the paying hospital. That's something which you can do. Maybe, at least in some cities, if the insurance penetration is high, at least that is one thing where you can, those patients maybe you can spend more time as a counselor, but they don't have insurance, we don't ask them, we don't give them a choice unless the patient themselves ask.
So according to your experience, because sir is telling they have time, can I ask one more?
Yeah, it's like she said, in the camp we don't promote the paying surgery or any options which we do on the paying side. But if the patient talks about it, that he wants a particular type of surgery lens, then we ask them to come to the hospital where they have to re-register and then go through the whole process.
So now the big debate is happening not to do these free eye camps and all those things. More common in the metropolitan cities now, many doctors are creating groups and awareness and all those things. How tangible it is that it will draw the paid patients? Because one of the story which I saw from Arvind is that after doing a camp in somewhere in part of Kerala, then after few years, the Malayali name board was added as Arvind Eye Care System, because patients started coming there, and that was the third name board which was added. So till today, do we have any studies how we can tangibly assess doing these free camps and how much of patients would they come for the paid section?
See, if you look at the prevalence of blindness, today it's about 0.3%, okay, the whole 0.4% you can say in the population. But if you see in the urban area, it is 0.1% or less. If you see in the rural area, it is 0.6 or 0.7, almost like 4-5 times higher in the rural area. The second, if you take educated and uneducated, again it is like it is like 300% higher in the uneducated person compared to people who have done past their 10th standard. And again, if you see the women, it is about 40% higher than in men. Okay, I mean, these are all people, and today in Aravind, it's only 40% pay. 60% of them come through the pay, through the free, either through camp or other thing. And again, the national surveys show that only 30% or 35% are paying across the country. So unless, and even if we recently did a survey in the old Theni district, where the CSR is probably the highest, about 11,000 per million what we are doing, against a national average of about 5,000. Even there, we found that what we are doing is the incident cataracts. We are not doing the backlog, even today. About 5 times of what we do in a year is what is there as a backlog. So with all this, I don't think, people cannot afford, people cannot access care.
Justified, sir. Free eye
No,
camps.
so I don't think the free surgery or eye camps may not go away. Probably it may be replaced by the vision centers or primary eye care centers in rural area, but the eye camp or the concept of free surgery will be there maybe for the next, unless you have an insurance, government covers everybody, that insurance is there, or the socio-economically country becomes much better, there is no other solution. Yeah.
Thank you, sir.
Yeah.
So this is regarding the wrong IOL power. Actually, recently we had one incident. On the IOL power calculated was -1, and the IOL power given to the OT was also -1. On the box also, there was a +5.5 power IOL. Wrong packaging by the manufacturer. Unfortunately, it was not verified by the surgeon on the table, and wrong IOL was implanted. So after that, we have started verifying on the table as well. Inside the box, what is there, that also is being verified. Just an incident I wanted to...
Yeah. So I'm not sure how you can verify the power inside.
So
On
Is
the
it
lens
the
box, on the lens box.
Lens box, okay.
Inside,
Inside
not
the-
the cover, but on the lens
Okay.
box. But actually, this is can happen, but very, 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 very rare. I mean, this is probably the last common thing,
yeah, this is the
especially in
first,
today's
incident
world.
we have
Yeah,
noticed
but
in our
I'm sorry, it's good that you have identified this, but it's extremely rare. I think today the manufacturers, so there have been situations when we have post-op refractive surprises, it doesn't make sense, and also we go back and we look at the batch and check. But there will be something with the calculation or the way the eye behaves, but I think this should be the last cause if you don't know the cause of why this happens. But yeah, but it's good that you have this.
Yeah. But we also had instances, where we had this refractive error because we exactly implanted, because the patient needed -1 both the eyes. We implanted, one eye had almost no refractive error, other eye had a +3 error. So then we explanted the whole IOL and sent it, the power was not -1, it's something else. So that also can happen. Yeah.
Yes, sir.
Yeah, I mean, if there are no other questions, we'll close. I would like to really thank Dr. Haripriya Dr. Shivakumar and Dr. Magesh for their presentation. Plus, they are also quite passionate about this, and they really get involved across all our hospitals to make sure that these are all taken care. They meet with everybody once in a month across all the hospitals and go through all the, the way we really learn is from the near misses, not from the incidents. Incidents are very less, but the near misses where we have to learn. And once you are able to put in place a process, the whole interaction between your staff and the patients also improve. So that is where the real the benefit is there. And the way the patients develop the faith and trust in your system also will improve when you have such a process in place. So it's a win-win situation for both of us, for the doctors and also for the patient. So thank you.